Welcome. So Armenian Mental Health Initiative is started. We're a task force, and most of the members, the core members, are here today. So we really came together in response to the war in Armenia, in Artsakh, and our main focus really is to support Armenia and Artsakh in any and every way. Our primary goal as a mental health initiative or behavioral health initiative is to provide them whatever they need. So we work with them hand in hand to have their needs met. So if they are requesting education, we either provide it ourselves or find experts who can do so. If they're needing consultation, we do that. If they're needing trainings, whatever it is that they're asking for, if they're needing consultation about infrastructure, whatever we can do to help, information about VA and how we run VAs here. So that's really mostly what's going on. And I'm going to keep it really brief and turn it back to Lara to introduce our speaker for today and just to give more of an introduction if she'd like.
Thank you again for all joining. Some of you may have seen the flyer. Some of you may stumble upon this. We're so glad that you're here. We are doing our first grand rounds. So this is something we're hoping to do more of. So let's see how this one goes. I'm really, really excited to present Dr. Talin Babikian. She is a PhD clinical neuropsychologist at UCLA. She is the associate director of the UCLA Brain Sport Program, and she is here to present her topic on traumatic brain injuries today. We also have with us an amazing soccer player from the East Coast, Alecko, and he is going to speak after about his experiences with TBI and teach us more about what it looks like in real life. So I'm going to turn this over to Dr. Babikian. Thank you so much.
Can you all hear me? Okay, great. So I'm very excited to be here. Everyone here has been someone new I've met on this mental health initiative helping Armenia, but I feel like we're family and we become close friends. So what I had planned today was to focus on traumatic brain injuries, obviously, as they relate to the military population. And we are going to talk about that. But because we have a special guest who has a background in sports, I also weaved a little bit of information about the sports angle of traumatic brain injury. So it's more of a potpourri of TBI. And I would like to just get some concepts across. It's really hard to go over a wealth of information. Each of these subject areas are an hour talk in and of themselves. But what I wanted to do is to talk a little bit about what is a traumatic brain injury and what causes the symptoms we see. What are some facts and myths directly related to sports-related concussions, talk a little bit about more severe injuries and the outcomes, then dive into comorbidities and what that looks like in terms of diagnosing and intervention, and then talk about some treatment considerations. So we're going to take a 30,000 foot view of these topic areas. I have a lot of slides, too many to go through in the time that we have, but I left them in there. So if any of you would like to have copies so that you have more specific information or more information about any of these topics, you can do that. But you'll see me as I go through the slides, I'm gonna highlight the points that I think are important takeaways and skip over them as I monitor time so that we leave enough time in the end for our special guest and also have some time for questions if those come up. So this is a little old in terms of statistics, but the numbers really haven't changed and the ratios are what I think are most important. So we pay attention to the folks at the top, but the bottom of the pyramid is an undefined denominator of the number of people who are impacted by a traumatic brain injury in the world, in the United States, and this applies to lots of different settings. What's really key is that a lot of other diagnoses or conditions get a lot of attention in terms of funding or awareness, but traumatic brain injury in the young population and youth is the leading cause of death and disability. So it's a big problem in terms of public health, and understanding it becomes really important. In the military population, and these numbers aren't too different in the civilian. In the last recent wars in the US, about 10 to 20% of those deployed have been estimated to have a traumatic brain injury. And of that 10 to 20%, a majority, about 80%, fall in that mild category. So we can call it a concussion or a mild traumatic brain injury. I'm going to use those two terms interchangeably. So the bulk of the morbidity and the incidence is that mild group. There's different types of injuries. Again, if you think about sports versus car accidents versus military, the mechanism of the injury varies. So you can have, for example, in a sports-related injury, the head doesn't necessarily have to touch anything. It could be a rotational force, or if you think of like a car accident, if someone's seatbelted, that sudden movement in the brain, basically the brain moving in the skull, and that causes disruptions that we'll talk about. In the military setting, it could be ballistic. So if you think of a bullet, a simple example of a bullet penetrating the skull and the brain, it could be a blunt injury, civilian or military. So this would be the head hitting something else. So whether it's an impact from a car accident or a fall, or again, it could be sports related. And then what's really unique to military is the blast injury that has several components. So there's different mechanisms of injury overlaid on each other, which makes it a very complicated injury. You have the primary effect of overpressure from the blast that causes secondary, like shrapnel that can get lodged in tissue. And then the person in that blast may fall and then hit something. And then there's asphyxia and burns and other exposure. So there's levels of exposure that can be problematic. So something unique in the military TBI group that we don't see in our civilian populations. Here's just a schematic of what I described. And again, I'll leave these in there if anyone's interested. There are lots of different ways to define a traumatic brain injury, and these different organizations, these different bodies have various definitions of what a traumatic brain injury is and how to categorize it in terms of mild, moderate to severe. Most of the time clinically, so most of the literature in the clinical area, emergency rooms will use the GCS. You probably have heard that. So that mild end would be very little change in responsiveness in terms of eye movements and verbal responses and motor responses, all the way down to someone who's vegetative. The military may use a different categorization, but again, it's really trying to quantify the degree to which there's neurological impact. Let's talk first about what a concussion is. It's a biological process that affects the brain. Again, the brain doesn't necessarily, the head doesn't have to hit anything. It's the movement, sudden movement that's severe enough that the brain moves within the skull. And if that's severe enough, then you can have an impact that then would lead to concussive symptoms. So symptoms start very quickly. You don't necessarily have to be knocked out or unconscious, and you will get better. And most of the time, conventional imaging won't show any abnormality. Again, if this is a straightforward concussion. What's important to note here is that you have to have symptoms start quickly. So if someone had a suspected concussion and they were fine for 4 days, 7 days, and then all of a sudden there's a headache or something else, then you have to start thinking about what else is going on as opposed to the concussion itself. These are the common symptoms. And again, they, nothing out of the ordinary or surprising here. They tend to cluster under physical symptoms, emotional symptoms, cognitive symptoms. And you don't have to have a period of unconsciousness, although that's possible. What underlies all those symptoms is a nicely mapped out cascade, a metabolic cascade of events that happens right after a concussion. And we know that within a week to 2 week period, all these abnormalities, everything that's out of whack here, normalizes. And we know that this physiology underlies the symptoms that we see. So in this next graph, lots of pictures here, lots of components, but basically the different areas of how cells communicate with each other can be impacted by that metabolic cascade. And that's what underlies the symptoms that we see: headache, slowed reaction time, impaired cognition, vulnerability to second injury, etc. This graph, every time I get asked to talk about TBI, I try to weave this picture in here because it's very telling about what a brain injury is in terms of an energy crisis. So if you're not familiar with a PET scan, the image on the right is a normal scan. So that's the normal energy patterns of someone who has a healthy brain. So GCS, remember that categorization would be someone who's fully alert and engaged. The middle image is of the brain of someone who's comatose, so their GCS is much lower, but notice that there's a definite hypometabolism. There's an energy crisis in this second image. What was striking was this first image was of a college student. This is a scan down at UCLA, who again has a GCS of 15. He had had an injury a couple days before his brain was imaged. He walked to the scanner, he lay down to the naked eye, he was perfectly fine. But this to show you that the crisis that the brain is in right after a concussion is not too different than someone who's comatose and in the ICU. So that's why it's so important to identify a concussion early and to manage it appropriately, so that the brain can have a chance to recover from that metabolic crisis. So when the brain is in that crisis, there's slow reflexes, there's slower thinking, there's poor playing style, genetic risk may be at play. So no surprise then most of the repeat concussions happen within the 10 days of the first concussion, which is why it's important, as the saying goes, if in doubt, sit them out. So that we avoid a second concussion on top of an already vulnerable brain, which then just prolongs the symptoms. This is someone in our lab who looked at, these are rat models of brain injuries, but if two injuries were not overlapped on each other, the animals that were studied recovered within a couple of days. But when the injury happened before the first one was fully resolved, then there's a prolonged period of symptom experience. And we see that in humans as well, real quickly here. These are Italian soccer players. First time concussion, within a month, their metabolic functioning normalizes. But for the subgroup that had a second concussion before their first one was resolved, they took about time and a half to recover instead of the normal time. So how do you diagnose a concussion? It's absolutely a clinical diagnosis. There's no single tool. There is all sorts of things that are being sold and introduced because this is such a hot topic. But at the end of the day, there's no single instrument that can diagnose a concussion, but there's some very helpful tools. And these are the ones that if anyone's interested, you can look at. And the one I'd like to highlight, if you work with the military population, is the military version of the ACE. And it looks something like this. It has a section looking at cognitive skills. It has a section with a good history intake, looking at neurological functioning, ocular functioning, vestibular functioning. And that can be used to not only diagnose, to help diagnose as one of the tools, but also to monitor the symptoms once a concussion has been diagnosed. This is a summary of cognitive impairments. So these are neurocognitive impairments in professional sports. So studies looking to see whether continual exposure to head impacts result in poorer functioning. And so for the most part in professional sports, there is some effect in cognitive performance. That's not so present. The jury's out. It's half and half when we look at amateur sports. And again, it's a matter of amount of exposure and type of exposure. A lot of times there will be questions about gender differences. So why is it that more males are getting diagnosed with concussion? And the answer really is because more boys, men, are involved in sports that would put them at risk for a concussion. Once we control for that denominator again, girls actually are at a higher risk. So if we look at the same sport, H is high school, C is college, girls are at a higher risk than boys, where there are both genders playing. And there's lots of theories about why that might be. There's clearly some possible hormonal differences. It could be the neck sort of muscles and neck strength, but there's also quite a bit of social cultural differences too. So girls are more likely to report symptoms. They're more comfortable reporting symptoms. And one study even looked at the gender of the clinician. So if a boy and a girl patient reported verbatim symptoms, the girl's symptoms were perceived by the clinician to be higher. So there's lots of different factors that go into the gender differences that we see. I'm going to skip over this slide and show you this next one that really highlights how overlapping concussion symptoms are with a number of other things. So for example, the four main categories are in the middle. But if we take someone who's a young athlete for whom the sport is very, very important, and we pull them away from the sport, I always tease that, it's like we take away a young person's ability to do their sport. We tell them to go sit in a dark room. We take their phone away. We tell them not to have screen time or socialize. And we say, come out when you're not irritable. And that's just not going to happen. And so this graph to show you that there's quite a bit of overlap between what we think are concussion symptoms and what other things may be going on. So for example, if the person, the patient, the athlete has any kind of pre-existing traits of anxiety, most of the time that gets attributed to the concussion when in fact that was a pre-existing condition. If they're getting messages from the media that their brain is not going to be the same anymore, that they're going to get CTE, that they can't return to their sport, they're going to have stress, worry, and anxiety, not because their brain is concussed still, but because of these very expected things that may be happening. And all of these, I'm not going to go over every single category, but all of these are the number of the type of symptoms like pre-existing attention problems, learning disorders. Sleep is in every single category here. If someone's concerned, depressed, worried, they're deconditioned and they're not sleeping, of course they're going to have somatic problems, emotional problems, and cognitive problems. So the point of this overlap, the diagrams here, is that when we have someone come to us because they had a concussion and they're having symptoms, the natural tendency of a clinician is to attribute the symptoms to the concussion, to the brain injury, and ignore what else may be contributing to what's happening. The analogy I use in clinic is, it's like there's this snow globe, and the concussion is the snow globe being shaken. Once we put the snow globe down, we know that those snowflakes, due to gravity, will settle down. And so if they're not settling down within that expected period of time, we have to look at some other factors that are now contributing to those snowflakes floundering about. So it's one key clinical piece that I think is really important. So to summarize the outcomes following a concussion, we know that the course of mild TBI concussion is self-limiting, it's very predictable. Permanent problems after single uncomplicated concussions are very, very uncommon. Psychological problems, neurological problems are uncommon. And most of the time in adults, within the first 1 to 2 weeks, that metabolic crisis resolves, and so do the symptoms. And in children, it's a little longer. So we give them maybe 3 weeks, 2 to 4 weeks maybe, to let everything settle down. If things aren't settling down after that period when we know things should be, then we start looking at some other factors that may be contributing. So again, these are things like pre-existing maybe subthreshold learning issues, subthreshold anxiety that's now kicked up. In one study we did with, I think it's probably the largest emergency room recruitments of kids with concussion, we saw that the best predictor of the kids who had significant problems a year after was whether or not they had cognitive, emotional, or behavioral problems before. So the fact that they had a concussion was not a relevant piece of the equation when we want to predict who has problems a year after the injury. So brings me to this next set of slides. I always, again, try to sneak these in here because I think they're so important in terms of messaging and media and the language that's used. Because a lot of times this kind of sensationalization of risks after a concussion can have more damage than do good. So we all know Sanjay Gupta, we recognize that face. Every household, I imagine, trusts that face, our politics aside. And so when we see him talking about, headlines like this, CNN headline, CTE found in 99% of studied brains from deceased NFL players. Well, that's accurate. And what Sanjay Gupta says is accurate. What the layperson takes away, though, and doesn't realize is that it's 99% of the brains of players who had such grave problems when they were alive that their families decided to donate their brain to be studied. And that's a very small group. But people just look at 99% and run with it, so that when you do get little Johnny or little Armin who has a concussion for the first time with no other complications, parents who've seen this or the athlete who's seen these headlines then start worrying and pull away an activity that frankly, probably it has much more health benefits than the risks of the concussion itself. So another one is FDA approves first blood test for concussion. Well, that's not what the FDA approved. The FDA approved a blood test that would test for the likelihood of testing positive on a scan in the emergency room. That is not a test for concussion. But again, these kinds of headlines get mixed up in our media messaging and become really important. And why that's important is as opposed to that 99%, when we actually look at the real denominator of NFL players, about 3 to 4% of NFL players will develop CTE. That's still quite high, but it's not 99%. What's left out and what doesn't get in the news coverage is that there are at least 20 other pathologic conditions that are associated with the marker of CTE, including Alzheimer's and a number of other things. And that those deposits that are markers of CTE are found in drug abusers. So for example, 44% of opiate abusers will have that compared to about 20% of controls. And that a large proportion of the surveyed NFL athletes reported, 71% reported abuse of opiates. So not just use, but abuse. So all of these factors need to be taken into account before sensationalized and anxiety-provoking messages are shared with the population. Again, this applies not only to sports, but also any other injury, including the military population. If there's a soldier who's had an injury and the messaging to them is that their brain is never going to be the same again and they're at risk for dementia, that has some grave consequences. So the language that's used is really, really important. I'm going to throw in a couple of interesting studies here that looked at the brains of let's do this one. So folks who played football in the 40s and 50s, who were now at the time of this report much older, football players versus band players had no difference in the rate of dementia, and football players versus other sports also had no differences in terms of the rates of different kinds of dementias. But what the problem is, we have athletes who have, on the basis of their concern for CTE, have taken their lives. So for example, one athlete left a note donating their brain to the brain bank to study for CTE. Turned out that there was no evidence. And the problem there again is that suicide, especially in youth, is one of the most contagious social behaviors. So if we sensationalize it on TV, only report the glorified description of the people who have taken their life, and there's repetitive, ongoing, excessive reporting, this has grave consequences in terms of a public health outcome then is being attended to by the people who write these stories and the networks that carry them. So lots of myths about concussion. I'm going to leave this in here for the interested folks to look at later, but really summarize by saying, this was a meta-analysis we did where we looked at whatever published articles there were up until 2009 when this paper was published. This is in children, so the effects are a little more dramatic because in children there is development is kind of a moving target, and kids can be much more vulnerable. So in adults, these differences aren't quite as striking, but the same elements apply. If you have a mild injury, there may be some challenges cognitively at the beginning, but most people recover. Moderate and severe injuries may look closer together at the beginning. The moderates recover, although they may not fully catch up to their peers. The severes are the ones that are challenged because as time goes by and as they fall behind in normal developmental acquisitions, then they may look farther and farther behind of their peers. So I wanted to introduce you to this concept because we'll come back to it when we talk about more severe injuries. So the complications from a more severe injury can be really vast. And again, each of these topics is its own area, but clearly there could be endocrine issues, there could be neurologic issues like ongoing seizures, cognitive deficits that affect educational, vocational problems, personality changes that could affect relationship issues with family, chronic pain, including migraine, difficulty with adaptive functioning, physical limitations needing support, and mood and self-esteem. So each of these, again, is a topic in and of itself, which warrants a really multidisciplinary, multidimensional approach to treatment. If we look just at cognition, these are the bread and butter of what neuropsychologists like to measure. And again, across the board, we see that the more severe the injury, the more impairments people will have in these areas that we measure. Most of the time, the degree of deficit can be predicted to some degree by time since injury. So the longer it has been since the injury, the better the outcome. Age, there's some plasticity issues. So younger, if we talk about very young kids, younger is not necessarily better. So if the brain has not, in this sort of diffuse injury, if we disrupt the networks and the connections very early before they're formed and before certain skills have come online, we've we've disrupted that trajectory. This is very different than other kinds of injuries like hemispherectomies, where an entire hemisphere may be taken out or part of the hemisphere may be taken out. But because that's a more focal insult or an injury, sometimes younger is better because the brain is plastic. So there's some dynamic aspects to age and its impact on outcomes. And then a number of clinical things that no one's going to be surprised by. So how long they were unconscious, how much do they forget? All of these factors predict outcome. I'm going to skip that piece. I'll leave all this in the interest of time if anyone's interested in the biomechanics of predictors of outcome. What I wanted to focus a little bit on was the non-clinical predictors of outcome. So we can't go back and change how long someone was in a coma and how many seizures they had or what the volume of their hemorrhage was. But there's some aspects to their psychosocial functioning that we know impact outcome and we know are important. And the farther we get from the injury itself, the more these other factors become critical. And there's some protective factors too, in terms of connections and how connected patients feel with other family members or members of their community. And I'd like to come back to some of these outcomes. But basically the bottom line is it's not only the kind of injury that matters, which is what most of the research focuses on, but it's the kind of head, and by head is the person. It has many dimensions. It's a moving target, especially if we work with youth, and it's molded by genetics, it's molded by environment. So the more we understand how broad that net is that affects outcomes, the better able we are to then come up with an intervention plan that's multidisciplinary, that's multi-pronged, that can help improve a patient's outcomes. Real quickly, I'm going to introduce you to, this started off as my fellowship project 15 years ago, and it's turned into a really interesting series of studies looking at youth with a more severe brain injury that we studied twice, 2 to 4 months after the injury and about a year or so after. And the original idea was that we're going to look at these patients who had an injury, and we're just going to follow them over time to see what the natural trajectory of recovery is. And lo and behold, there was a surprise twist in there that I think is very telling and important to look at. And that was, instead of looking at our traumatic brain injury group as a whole, as heterogeneous as that is, we looked at this one biomarker, this one test where we decided to measure how quickly information would transfer from one hemisphere to the other. So we're going to call that interhemispheric transfer time group. There's a slow group and then there's a normal group. So there's a group of kids whose transfer time was much longer. So that's the integrity of the corpus callosum, than the other also brain injured group whose transfer time was not different. And what was interesting is that those two groups, and they look like this. So this is our healthy control group. This is our TBI group with the normal transfer time and our TBI group with slow transfer time. We couldn't find, and I'm sure you're all thinking, well, those are the more severely injured patients, or those were the ones who were in a coma longer, or maybe those were the ones who had seizures. We looked at every single medical permutation. We charted every detail from their medical records. We had volumes and volumes of information. We couldn't figure out how these two groups, in terms of their traumatic brain injury, other than this one measure, which is some of them have a slow transfer time and some don't. We looked at age, we looked at sex, we looked at family factors. None of it panned out. I'm going to skip over to this slide, which shows you a schematic of what happens to those different groups. And this is an image that made the cover of this journal, and it's hanging in the NIH because it's such an awesome summary of and an example of how we can't group TBI all into one because there's really different dimensions. The cooler colors are better integrity of these fibers. That's what this is measuring, fibers in the brain. So within a 1 month period in a healthy person, growing person, these are youth, the colors become cooler, which means that the white matter, the connections in the brain that help us, the cells communicate in our brain are becoming better connected and more integrated. So this is a healthy pattern of development. In our slow group, or TBI, I'm sorry, in the normal group, also head injured, but their transfer time was normal. We see some recovery. We see that within that year's time, the colors are becoming cooler, which means even though they show quite a bit of disorganization at the beginning, that they're recovering. What was striking, what we didn't expect, is that the slow group actually showed some degeneration. So not only did they not recover, they got worse. So we wanted to see, can we identify what determines which person ends up in which group? And I don't have the answer, but we're working on different elements of this. You know, there's the you've all heard the biopsychosocial model, but we have the immunoneurobiopsychosocial, and then I would probably add cultural here, because this spectrum is really, really wide, and all these factors are very much entangled with each other. I'm going to skip over this image and really get to the crux of the findings, which is the biology may differ, and the biology is governed by our genetics and our epigenetics. So not just our genes, but we may have genes that aren't expressed unless a particular experience is presented to us. And the experiences can be negative experiences like an injury or child abuse or psychosocial stress. Or that experience could be a positive one, like enrichment and exposure to lots of different things that would create an environment where there's resilience instead of risk. I'm going to skip over all the inflammatory theories and risks for why we think that one group ends up degenerating versus the other group, and focus on the psychosocial community piece, because I think this piece of that spectrum doesn't get as much attention. You're all mental health providers. None of this is new to you in terms of parenting styles. But these parenting styles are linked to medical outcomes to some degree. So that in the upper left here, the authoritative parenting style, where there's high sensitivity, high emotionality, but there's also high structure. These are the kids who, after an insult, tend to do better. And the insult can be cancer, experiencing cancer, or recovering from a brain injury, or a number of other cognitive, academic, and mental health outcomes. And the worst group is the bottom right corner. So these are families who are low in emotionality, but also there's very little structure. And in the TBI literature, these factors are also very connected to outcomes. So independent of all the medical things that we are able to characterize and quantify, we know that the less favorable home environments, like the more permissive parenting, reduced resources, particular parenting styles have a negative impact on outcome. Externalizing problems are more often present when there's a caregiver with mental health issues. This is micro hemorrhages in the brain did not predict social outcomes, but caregiver mental health and family functioning did. And to some degree, parental favorable parenting behaviors buffer poor outcomes. If we have time at the end, I'll tell you a story about one of the participants where this really rang true. So our initial thoughts are that, kids, adults even, who grow up and have had this long stretch of certain experiences, either develop risk factors or resiliency factors when it comes to a point in their life where they have to deal with a traumatic event, a traumatic medical event, a chronic event, or um, uh, you know, be vulnerable for things like prolonged neuroinflammation or other physical inflammation. So the connection of I'm talking to a group of mental health providers, I feel like I'm preaching to the choir, but even we sometimes forget the degree to which some of these factors that are outside of the person's biology impact their biology, and vice versa. And there's some literature that's emerging that shows that. So perhaps the image I showed you at the beginning of, these two groups, and I said the severe group tends to fall off the curve, maybe the picture's more like this. And there's a number of, so on average, they may be falling off, but really in reality, there may be different subgroups that, depending on what they brought to the injury themselves, may have a different trajectory. And that's highly variable. So outcome is not linear, and there's some issues with intervention. So lastly, real quick, I'm going to talk about PTSD, and then we'll switch over and hear a personal story from our guest. Again, preaching to the choir, I'm not going to go through. These are the different symptom clusters, categories of PTSD. And the reason I've put them there is because I want you to go back to this list. So if we have a concussion in the middle, those are the concussion symptoms in the middle. How many of these symptoms are also PTSD symptoms? And there's quite a bit of overlap. So when we're evaluating one, we can't ignore the other. And in certain environments, they go hand in hand. This may not be so much the case, for example, in a sports concussion, but if we're thinking about the military population, or if we're thinking about a civilian car accident, or there was a brain injury, we can't ignore the psychiatric piece, the PTSD piece. And I say PTSD, most of the time, someone's symptoms may not meet the threshold for the diagnosis. So it's not just PTSD, but it's that range of symptoms all the way up to a formal PTSD diagnosis. There's still emotional experiences, and they have consequences. If you don't remember anything from this talk, I'd highly recommend this one thing that you walk away with, which is reading this book, The Body Keeps the Score. It's a little hard read. There's an audio book version of it that I found a little more palatable. I've read it once and I've listened to it twice, because I think every clinician, regardless of what your specialty is, would benefit from understanding how traumatic experiences, and again, it doesn't have to be trauma the way we conceptualize trauma, chronic stressors and experiences that create that level of fight, flight, stress response in our body. It really ties those experiences to aches and symptoms and ongoing issues in ways that are really hard to connect right away. But I promise you, this is not a life-changing book, but it'll change the way you do your clinical practice. So I highly recommend this book. And real quick, I'm going to talk about the military population. Folks, in general, outside of the military, actually, 90% of the population will report a traumatic event, but only under 10% will develop PTSD. And the rates of PTSD are higher if someone also has a traumatic brain injury. So something to keep in mind in the military population. I'm going to skip over all this, some more information, but really to wrap up by saying that part of the PTSD concussion coupling is the experience itself, right? Again, if there was a blast and people died and someone needs an amputation. There's clearly a traumatic event in addition to what's happening with the concussion itself, the neurology of the brain injury itself. And then the pathophysiology is similar too. But what also is part of the picture is that if someone has a brain injury and their processing skills are slowed, delayed, interrupted, then they also can't process the trauma in a way that will help them digest the experience, so to speak. So the overlap is experiential, but also physiological. So it makes sense that these two diagnoses are oftentimes coupled, and in the treatment of them, one can't ignore the other. So quick considerations for intervention, and we'll stop. So to treat TBI, whether it's a severe TBI, whether it's a more straightforward concussion that's not getting better in the manner and timeline that we expect it to, or if it's a complicated situation with a TBI and something else like PTSD, there really needs to be an interdisciplinary approach in the screening. Our clinic has a dietitian and an occupational therapist and psychology and neuropsychology in addition to the medical exams, because all of these factors are at play. And so if we're going to treat a patient whose symptoms are not resolving, we have to understand it from these different dimensions. And we need a good evaluation. So if our evaluation is inconsistent or incomplete, then we're missing a part of the picture. So in order to be effective, we have to know as many of the puzzle pieces as reasonable. The other suggestion is to not treat the TBI per se and treat the symptoms. And not to minimize the brain injury, but when families, and I see this over and over again in clinic, is when they're so stuck on the TBI. I've had patients who've come 7 years after an injury who had a relatively minor concussion, but they heard the word brain injury, and they've just never really gotten back into their life. So I tell them, it's like, if you twist an ankle, you're going to rest your ankle for a day or two. But then if you hold your ankle up for another year and never use it, the ankle is going to hurt, not because of the original twist, but because it's deconditioned. And very much the case with athletes too. A lot of times, they practice 6 hours a day and then they have a concussion and then everything is pulled back. They're not even able to go for a walk. And so they don't feel good. They're foggy, they're in a bad mood. And if we keep calling that your brain injury, we're just kind of making them go in that loop. So we want to break that loop, treat the symptoms, and then we see that they go away. Prioritizing high value targets. So if someone comes and they have lots of symptoms, they have memory problems and they can't sleep and they can't, they're irritable, and but we know that they have a horrible migraine. So if we intervene in one of those overlapping circles, it's going to have a downstream effect on a number of other symptoms. So identifying those high value targets, whatever that may be, will then help some of the other circles that I showed you a picture of. But then not forgetting the no-brainers or the low-hanging fruit. These are things, when people come to specialists, they're looking for the magic pill or the magic intervention, that special treatment. But most of the time it's these, they're not sleeping well. And that's why, they're sleeping only 2 hours a day. We can't ignore that. Or they're not exercising enough. They're not socializing enough. They don't have their routine. So the phrase I use is, if I could give you a prescription, I would say normalize your life to the extent possible. That's the only way to get back into the game. And then involving supports, spouses, parents, children, teachers, bosses, whoever that network is, so that everyone can be on board. Because if we take someone with a more severe injury, for example, and we take them out of their environment and we provide them a number of treatments, and then we send them back to the environment where they felt the dysfunction, it's not going to generalize. Sort of like that addiction models, we have to be able to provide the intervention in their life, in what's normal to them. So if they're an athlete, we go out sometimes and do the cognitive behavioral therapy we do as they're shooting hoops, instead of talking about it in the office. And then, like anything else, and again, I'm going to be speaking to the choir here, it's finding the meaning making of the experience. If there was some loss associated, if someone had to retire from a sport, or if they're amputated a leg, or if they lost a loved one, part of that grief process, obviously, over time, is to be able to make meaning of the experience, so that they can get back to feeling some level of control. So those are the very basic bird's eye view of interventions. And I'll leave you with this quote, and then we can transition here from our guest speakers and talk about some of these things as firsthand, instead of lab work like this. Trauma really does confront you with the best and the worst. You see the horrendous things that people do to each other, but you also see resiliency, the power of love, the power of caring, the power of commitment to oneself, the knowledge that there are things that are larger than our individual survival. And in some ways, I don't think you can appreciate the glory of life unless you also know the dark side of life. And I think conveying that to patients becomes really important. And that's from that book, The Body Keeps the Score, that I shared with you, that again, I highly, highly recommend that you read. All right, so I will stop there.
Dr. Babikian, thank you so much. I think this comes very timely for all of us. And even as mental health providers who have been maybe doing this for many, many years, we can still learn and cultivate our existing skills. So thank you again so much for sharing your wisdom with us. We will take questions for Dr. Babikian at the end, but right now I want to take an intentional pause and transition and invite Alecko, who we are very appreciative and glad to have, to share more personally his reflections, his experiences, and then after that we can take some time for more dialogue and question and answer. So Alecko, I'm going to turn it over to you.
Thank you so much. I'll do my best to follow up that presentation. Talin did a wonderful, wonderful job. I've seen hundreds of presentations about TBIs and concussions, and she really did an incredible job going through all that. So I'll do my best to follow that up. As Talin mentioned, it's an extremely complex injury. Going through it, I've unfortunately had to learn all about the human brain and how much of a phenomenon it is. But I'll quickly share my story in the limited time that we have. But most importantly, to complement Talin's presentation, I want to talk about the importance of medical professionals in this equation, because, and Talin touched on a little bit, when you're an athlete like I was, and now all of a sudden your world is flipped upside down, you need others to take care of you, because as an athlete especially, you're going to be in a state of denial of what you can and can't do, or trying to push it, or trying to block things out, and you're almost too tough for your own good. And that's when it becomes really, really important for those that are around you, whether it's your support system or the medical professionals, to really, really get in deep and try to help the patient as much as possible. From, I guess, where do I start with my story? For those of you that don't know, my name is Alecko Eskandarian. I was a professional soccer player. I'm from New Jersey. Some of you might know my dad, who was also a famous soccer player, and I kind of followed in his footsteps, and was fortunate enough to be a pro and play professionally for 8 years. Unfortunately, my career ended at the age of 27 due to concussions. And when I look back and I think about my journey through concussions themselves, it starts actually with my first ever professional match, which oddly enough, I don't remember at all, because in the match, I came in, I went up for a header. I accidentally got undercut from an opponent and a teammate. I collided and I ended up flipping over and actually landing straight down on my head like a spear. In looking back on replays and things like that, I was actually really fortunate that I didn't break my neck or do damage to my spine, potentially get paralyzed. But my head took the blunt of the trauma. So after that collision, I actually had amnesia for probably like 3 hours where I don't remember anything. I actually stayed in the game, which is a scary thought because I was kind of on autopilot. And I wish I could show you video, but I know on Zoom, video doesn't always transfer so well. So I'll spare you guys. But basically, I was kind of roaming around. And fortunately, my opponent noticed that I was out of it and kind of got the attention of my own team doctors, who then stopped the game, and I was removed from the match. Like I said, I had amnesia for like 3 hours. And it wasn't until later on that evening when I was in the hospital, it felt like somebody just like clapped in front of my face. And all of a sudden I was looking around and I was like, why are we in the hospital? I had no idea. I had no idea what happened or anything. My parents were there. They were pretty distraught. And I actually grew really emotional because no one was talking to me because they thought I was still out of it. And I kind of started freaking out of like, why wouldn't anyone tell me why we're in the hospital? And then they had to tell me like, we're here for you actually. And I was like, what? So it was a really crazy experience for me. That was my first diagnosed concussion. And in a weird way, I walked out of the hospital that night unscathed, other than I actually broke 3 fingers, which I didn't even know about, because on my landing after the concussion, I ended up breaking 3 of my fingers. So my head was okay, but I had to walk out of the hospital in a cast. So oddly enough, I was like back at practice the next day and took a few days off and felt fine. I had 2 more documented concussions after that, that again were not great, lost the consciousness, had symptoms. But again, after a few days, after a week, felt totally fine, got back into it. Then I had, it was my 3rd or 4th one, was a really, really bad one. Collision with the goalkeeper, full speed, his knee right through my skull. And on that one, immediately afterward, the symptoms were very different. And now I remember when I was walking off the field, I was even telling my ATC at the time, I feel like I have like a dead weight in my head. And it was something new. I'd never felt that before. And, you know, I went back into the locker room, took a shower and everything. And I was like, man, this feels like I have like a 2 pound, 3 pound weight that's just like sitting in my brain. So same thing, got checked out, did all the tests, all the cognitive tests, everything checked out. But even the next morning, again, just felt like I had this brick in my skull. And this ended up lingering for almost a solid 8 months. And it was brutal for me. I missed a full year after that. And I had a really traumatic experience actually with a neurologist who ran me through all the cognitive tests and actually cleared me to play. And I started telling the neurologist, listen, I'm happy that I'm cleared to play, but I still have this pressure that fills in my head. I don't know what's going on. And they were like, no, everything checks out. Your CT scan, your MRI, this, that, the other, your memory's good. So I began to learn how complicated this is and how important communication is. Because I got cleared, I went back to training and I was practicing. And every day after practice, I was getting these massive migraines. And I'm like, something's not right, something's not right. I ended up going back to that same neurologist. And again, this is a one-off, and this is 15 years ago. So times have changed quite a bit since then. But this neurologist was almost condescending. And he was like, usually I'm telling people that they're not okay. and they're trying to convince me that they're okay. They're like, with you, I'm telling you that you're totally fine, and you're telling me you're not okay. And I'm like, look, I don't think I should have a 5-pound weight sitting in my head. I don't think I should be getting migraines after practices or after I exert myself. And I had a really bad experience where I got a migraine so bad after practice that I almost crashed my car driving home. Right then and there, I pulled over to the side of the road. I called my team doctor and I said, I need to go to a different neurologist. So they hooked me up with the team neurologist for the Washington Capitals, the professional hockey team, because I was playing for DC United at the time. And I went in, I saw this neurologist. I told him my story. Right then and there, he's like, we're shutting you down for 2 months. And I'm like, I have a game Saturday. I can't get shut down for 2 months. And he's like, listen, I'm telling you right now, with all the symptoms that you have, with these migraines that you're getting, you know, it could potentially be fatal if you get hit the wrong way. Like you are still experiencing some severe symptoms. And finally felt like, okay, I'm speaking to someone who gets it, right? And I was really, really thankful because it saved my life in many ways, where now I learned more about the brain. I learned to take it more seriously. And the 2 months that he shut me down turned eventually into 10 months, and I was out for a full year. I eventually came back. I played for 5 more years. And then I had last one when I was playing with the LA Galaxy in a friendly match against AC Milan. Took a clearance off my face, broke my nose, and unfortunately, again, lost consciousness. And when I saw the replay, I was like, I think I'll be okay. I've dealt with much more impact, you know, on previous concussions. So I thought I'd be fine, but then I just got a whole new host of symptoms with vertigo and all these different things that just started compounding and altered my life. So that's kind of my journey through concussions. And that last one ended up forcing me to retire. Talin went through kind of that wheel of symptoms and emotions and all the different things that go into it. It kind of made me twitch a little bit because I think I went through all of that multiple times. But, you know, when my career was over, I was, again, 27, super fit, healthy. Soccer had been my life. And it seems like overnight, you know, the rug was pulled from under me. And now it was like, what do I do now? I'm now, the one thing I love the most, I can't do. And now I almost have to like reinvent myself. And I was in a really dark place, I would say, for 2 years, where, you know, you start to look in the mirror and you say, like, who am I? What do I bring to the table? What more do I have to offer when my special talent was now taken away? And yeah, it became really, really difficult. I'm really blessed that I had a strong support system with me. And I'm glad Talin mentioned at the end, because at those times, it was kind of like, well, don't do anything that triggers symptoms. Well, I was getting symptoms with anything. Like even laughing too much was triggering symptoms, even sunlight, noise, everything. So, you know, I really understood what depression feels like, because my life as I knew it was done. I couldn't do anything that brought me joy. And I finally got with another neurologist that worked, Mickey Collins, that worked at a University of Pittsburgh, and one of a great therapist that also was working out of LA with my team, who kind of put me on my own program where I essentially had to become my own doctor. And it was like, it's okay to have symptoms. It's not the end of the world to have symptoms. Let's just try to like build gradually so that they're not getting worse, or that you're not waking up with it the next day. And I almost had to retrain my body how to exercise again. And I had a bunch of other little things too. I had an eye issue, some vestibular issues, some balance stuff, some jaw stuff. I had a whole bunch of different things going on. And little by little, once we started tackling all of these different symptoms, and I just gave myself new daily goals, that's when I started feeling better. And it was physical, but it was more mental than anything else, of just like stopping. I felt I had to stop feeling sorry for myself, because there comes a point where you get in this lull, and I had this black cloud over my head where I would just be like, oh, I can't go to this party. I can't go to this concert. I can't go to a comedy show because it's too loud. And oh, when I laugh, this happens. I can't exercise. And I started thinking about everything that I couldn't do. And finally, I had to kind of flip the switch and say, you know what, let me just focus on what I can do and start from there. And once I did that and set little small goals, and when I say small goals, I'm talking about like one day I was like, I'm going to go jog outside. And I'm not kidding. I made it maybe 30 seconds and the thumping on the pavement, all of a sudden I felt thumping in my head and I cried. I was like, this is awful. And the next day I was like, okay, let's try it again. And then it was like, okay, I got through 2 minutes. And then it was like 5 minutes. And then, okay, let me get on a treadmill and let me control my heart rate. So this is all to kind of tell you it was a long, long journey. And through it all, I didn't want to talk to anyone about it because when I'd see people, they'd say, oh, you look great. How come you're not playing? Because it's such an invisible injury. It's not a scar. It's not something where you see blood or, you know, people can't see you suffering. And that is the worst part of the injury, is that it's really, really difficult to communicate. It's a catch-22 because I don't want to talk about it, because when I talk about it, it brings me down. But at the same time, when someone doesn't recognize what I'm going through, it's even worse because they now treat me normal, even though I'm not normal, but I want to be normal. So it's a really, really complicated scenario. And the mental damage that does is really, really taxing. So like I said, I was in a dark place and slowly worked my way out. Thankfully, I had some great friends, amazing family who helped me throughout trying to get through it and finding a new passion, a new joy in life. I went back to school, I finished my degree and started getting involved in different things. And as Talin mentioned, keeping that brain active and thinking and making sure I was doing crossword puzzles every day and just different things to just keep myself active. Finally, to bring you to present day, and I'll kind of rewind a few years ago where all these years, I almost became like an unofficial spokesperson to all athletes now who are experiencing concussions, because I was one of the first, if not the first MLS player that had to retire because of it. And now all of a sudden, parents were calling me, kids were calling me, all these guys. And I was like, man, I need to help myself before I can help others. And so I try to stay a bit distant from it. And finally, when I felt like I was in a good place, I came forward and I wrote an article in the Players Tribune, which you guys can easily Google and check it out. And this article that I wrote in the Players Tribune was almost like my like 100-pound weight off my shoulders of just kind of being like, this is everything I've been going through for the last 10 years. And I'm now in a place where I can talk about it. And I feel like I'm comfortable talking about it. And now I want to help other people to make sure no one else has to go through what I went through. And yeah, now I'm honored that I work at Major League Soccer and I sit on our concussion committee board. I'm on a task force with US Soccer. We work with FIFA, and the strides that we're making with raising awareness and making sure players are looking after each other and the referees and fans, teammates, like just the entire culture around it is something I'm really proud of, because like I said, when I was going through this, I had a neurologist telling me that I was cleared because I passed some cognitive exams. And so we've come a long way, but I cannot stress how important it is for all of you medical professionals to really be on top of it and to look deeper into it. Like when we're talking about the human side of this, it's not just a scan. It's not just a cognitive exam. It's not just telling you 5 words to repeat back to me. There's so much more that goes into it. And especially me being an athlete, it was really, really difficult to like tell myself I can't play anymore and to give up what I love the most. And fortunately, I was able to, through my support system, find that next path and the next journey. Some people aren't as lucky, and they, you know, in my conversations, there are a lot of people that hit depression and they struggle to get out. They really struggle to get out. And it's important that the messaging, the motivation, all that stuff stays constant to help pick them up out of a dark place. So I know I went too long. I apologize. There's so much more. I think I could speak for hours on this topic. But I can't stress enough how honored I am to even be with this group, how thankful I am for any medical professional that supports patients like myself, whether they're athletes or in the military, getting back on their feet and living a normal life. So thank you for having me, and I'm happy to answer any question that anyone might have.
That was such an amazing summary and so real. So I really appreciate you being so open and honest with your experiences from the beginning. And it's really good to hear that you've taken that experience and have translated into something that's giving your experience meaning. As I was listening to you, obviously at the beginning, there's a real injury and it sounds like you had several. But then it really comes to the forefront again, how important the mental health piece of this is. And it's so intertwined with the symptoms. So ignoring it really makes it's like treating someone in the dark. It's shooting in the dark if we just think of it as a brain injury, because this other force takes over when, again, we take away the very thing that energizes you as a human being, you as the identity. And then we want you to feel better before we say you can go back to it. And it doesn't work that way. So it has to be done in a very unified fashion of minimizing the risk, but having someone like you be able to go out and do the very thing that is going to make them feel better. So I wonder what you would say to, I don't know if you have kids or maybe family members, but if you were talking to a young person with aspirations of being in professional sports, what would you recommend to them and how would you describe the risks and benefits?
I mean, there's definitely risk with sports, right? I mean, these days there's risk with everything. I feel like, but sports to me are so important because I've learned so many valuable life lessons through sports. So I would always encourage people to continue to pursue sports and activity, and not have any trepidation with that. With that said, I think it's more about the treatment of if you experience a concussion or a brain injury. And I think too often, especially in the past, it was almost like a toughness thing, right? Of like, can you follow my eye? Are you good? Can you like kind of slap it out of you a little bit and get some smelling salt and you're good to go, you're back in there. And your team would be like, oh, you're being tough and you're not letting us down. And I think it's really, really important for parents, coaches, teammates, medical professionals, everyone to understand it's just not worth the risk. And it's what I'm preaching now at a professional level, where even if there is a 1% chance that someone is concussed and experiencing symptoms, take the time to evaluate them, remove them from a match, take them out of, whatever exercise they're doing. And you know what? If nothing's wrong with you, great. You live another day and you get back at it. But more often than not, like you said, the brain is a muscle like anything else. And if you hurt it, you gotta allow it to rest. And the best way it was ever described to me, actually, which was a neurologist used this analogy. They almost said it's like a computer. When you have a lot of different windows open on your computer and all of a sudden you kind of hear your computer like overheating a little bit, that is like your brain concussed. And so the goal is to try to close as many of those windows as possible, remove distractions, and let your brain rest and heal. And when you're able to do that, my experience was more often than not, that's when you can kind of gradually see improvement and ensure a healthy return to play.
Yeah, it's that whole, if in doubt, sit them out. And it's not only, there's the culture of the team, but then the policies and the laws, which are coming online. In the last 10 years, there's been a dramatic change in terms of how concussions are managed. And I think every single state now has a law regarding youth sports. But it has to come from bottom up and top down in terms of the messages. Again, I go back to the messages of being able to speak up if you don't feel well, being comfortable telling someone that you feel your teammate is, and removing the stigma that we've associated with being weak if you're concussed and not pushing through, or being weak if you have mental health issues and not recovering. It needs to be addressed as a society, but also in interpersonally and within our leagues and professional organizations. And so I'm glad to hear that you're having gone through it, you have personal experience to be able to help the organizations put policies in place that are going to be helpful.
Thank you so much, Talin. I echo everything you've said, and I think you did it much better than I could have articulated. So thank you so much. Alecko, I think I speak for all of us on this call. We are incredibly touched and moved by your openness and transparency in sharing your experience. You know, I think I'll speak for myself personally. I'm certainly moved by the resiliency and the ongoing desire to want to cultivate these types of dialogues that are just so necessary globally. I think more particularly in our community, in the Armenian diaspora especially. So immense gratitude to you. And also, you know, I think we all will take away a sense of inspiration to continue to contribute ourselves and invest ourselves into our community with regard to mental health as a whole. So again, thank you so much. I also want to say no worries about taking up too much time. I think we could just sit here probably for several more hours. And I also recognize in the interest of time to be mindful of that too. So we really want to give people an opportunity to ask any questions. Before we do that, I also want to let Talin and Alecko know I've been looking and monitoring the chat. There's a fan club currently taking place of the Alecko and Talin duo, so feel free to read through that. But yes, if anyone has a question, perhaps you can write it in the chat and then we can read each one out loud. Yeah. Or comments, particular comments, feel free to mute yourself.
I believe there was a question from Herine Dr. Galstian. She said, Dr. Babikian, very insightful. Do you have recommendations on mental health treatments in patients with a history of TBI? As a PCP, I often treat depression and anxiety and have seen patients who have had concurrent TBI. Do you have any guidelines? And I think Dr. Galstian is still on, so she may be able to expand upon her question unless you want to answer it straight away.
Sure. So I think it really depends on the issue. There's no single treatment model for what you're describing, right? So it's a matter of knowing all the pieces of the puzzle. So if there's history of depression, anxiety, and there's the concurrent TBI or history of TBI, it's important to know what the symptoms are and how that TBI is being attributed to the current symptoms. Sometimes it's very relevant. So if it was a significant injury and it's causing them difficulty remembering, for example, steps in something you've introduced to them, that's important to know. If it's causing executive functioning problems where there's disorganization of thought or how they manage their day-to-day life, that's important to treat. Other times the TBI history is irrelevant and it's actually a burden. So people come with symptoms of depression and anxiety and they keep talking about a brain injury as if that's the kernel, that's the sole reason for their mental health problems. And the best thing to be able to do in that situation is to uncouple those two things. So it really varies depending on how that TBI is actually manifesting itself in the patient you're seeing.
Thank you.
I think there's another question from Robin. If you're on now, feel free to unmute yourself and ask the question, but it states, what is the best treatment? I'm not sure, Robin, if you want to expand on that question. I don't know if Robin is on this call.
Can you hear me?
Yes.
Yeah, I'm having trouble with the camera, but the audio seems to be okay. I'll fix it after I get off. So I just wondered, the body keeps the score. Vanderkoff talks about EMDR. He talks about EFT and thought field therapy, and he talks about a lot of body techniques. But again, he is talking about PTSD and not necessarily brain injury. So I just was wondering how those fit into brain injury. Concussion.
So again, it's really hard to say there's the single best treatment for TBI because every single patient will have their own best treatment. But what I was trying to impress upon you is in order to best treat your particular patient, you have to have a very sound understanding of all the elements that are contributing to their symptoms. So sometimes it's a migraine that's driving everything else. So then they have to get migraine treatments, the gold standard migraine treatment. Sometimes it's an underlying anxiety disorder. There's a catastrophizing tendency or they're ruminating. So then that needs to be treated. If it's a dysautonomia, then maybe some mind-body techniques like breathing exercises might be helpful. So that's why I can't say there's a single best method. I think the single best approach is to have a really solid screen of all of these factors, everything in those circles, so that you can prioritize what's at the top and then address the priorities so that they'll have a trickle down effect on the other symptoms. Because most of the time you don't have people show up with one symptom, you'll have a whole cluster of symptoms.
And Talin, just to expand on that, that's the one thing I went through with almost having a support group of athletes that we were on like these group chats and texts and calls. And all of us were going through the same thing, but we all had different symptoms. And it was really, really frustrating just from a non-medical standpoint to be like, well, is mine worse than yours? Or is that good? Is this bad? And it gets really, really taxing because you start overthinking every single symptom as well. And so there'd be guys who you're like, oh, my neck, I can't turn one way. Whereas I'm like, oh, my eye, when I'm looking in my rearview mirror, or all these different things. And you start realizing, wow, there's so many different symptoms. And then the effects of those symptoms, how they compound, can be so different with every person. So I know for me, when I'm talking to people, I never use like any sort of specific guidance because every single case, as I know, has been completely different.
And I would add to that in that case, though, the clinician relationship with you is really crucial because, there's a study that looked at just psychoeducation. So the people who at their first visit had someone explain to them, hey, this is normal. This may happen. If that happens, we have a treatment. That really sets the stage for the patient to feel like they're in control, and even if something is interfering with their well-being, that there's something that can be done about it, as opposed to you're brain injured, we don't know if you'll ever feel 100%. I mean, as soon as you hear that, you're gonna live the prophecy, right? So that's why, as a clinician who works with people with a brain injury or with a possible brain injury, knowing the factors that impact outcome, including how these things are framed and the expectations that are put in place, are really, really crucial. Just like I imagine it would be in any other complex medical diagnosis like cancer or anything else. There's a difference between we've seen this before, we expect this, we're going to try this and we're going to monitor and we're going to watch, as opposed to you may die in 6 months. It's that same analogy.
Thank you, Talin and Alecko. I think we'll take maybe one or two more questions, but the one question says, what resources would you recommend besides Body Keeps the Score? Talin, I don't know if you and Alecko want to send us something later and we can send it out to the whole team who attended today's grand rounds. If there is one last question, and then we can wrap it up. Okay.
No, I have a question / comment specifically for Alecko. Is there something you could say to possibly the providers that are in Armenia or anywhere that are treating the soldiers, or maybe an indirect message to the soldiers right now? Because I think spirits are low, and even though your injury is different, I think the same issues are relevant here, and we would love something because this is going to be shared in the future.
Yeah, absolutely. No, I hate to even compare, my situation to any soldier and what they've gone through. Obviously, completely indebted to their service. But I will say it hits close to home for me because my best friend is actually an Army Ranger who's in the U.S. military, and he served 2 tours in Iraq. And oddly enough, he had a TBI as well. So we were going through it concurrently when I retired from soccer, and he actually came home because he was sent home from his injury. So what I can say to our soldiers and anyone that's going through this stuff is to attack this just like you've attacked anything else in your life. And that means being smart about it. You're not going to get results in one day. And when you don't get frustrated. It's one of those where you have to truly take time to assess what is going on with your brain, learn about it, educate yourself about everything that's going on in your particular situation, and then try to tackle it one day at a time. And like I said, what got me over my hump is when I stopped feeling sorry for myself and understanding, okay, rather than just thinking about what my old reality was, start focusing on what my new reality is and how to dig myself out of it and make a better life for myself moving forward. And when that mental hurdle is crossed, then you can start, reaching for that competitive edge again to find new games to play of how to just improve and progress. And it's tough. It's a long journey for some, and for some people it's relatively quick. That's another thing that I have found very interesting is that even timetable, with any other injury, okay, if I tear my ACL, if I break my arm, sure, 2 months in a cast, 6 months after surgery, whatever it is. With this, there's no timetable, and it's extremely, extremely frustrating for anyone who's competitive to not have a timetable of when they can return back to being active. And I think that patience and being methodical about taking it one day at a time, taking a deep breath, and understanding what progress is, that is the most important thing. But I for sure am evidence, and I can tell you I was in a really dark place, guys, like really, really tough, where you start questioning a lot of things and what your life is going to look like and what your value is. And I can definitively say that it is 100% worth the fight to go through it, tackle it head on, and you'll be a stronger, better person coming out of it.
Thank you so much, Alecko. I think you highlight, so many important points. Ultimately, to be compassionate with yourself and patient, and also that same message, I think, hopefully will resonate with our healthcare providers in Armenia too, to be patient.
And to add on that, to be vulnerable as well. That's another thing. As an Armenian man, we always want to be Chabad and not show any weakness and not talk about it. And like I said, I went through that too, of not thinking if I just ignored it and blocked it out and was mentally strong enough, I would just magically get better. But it really took kind of hitting rock bottom and being vulnerable to even let out, emotions that I, didn't ever want to even visit, to let it all out before I could start to make progress. So my heart is with everyone. I'm truly praying that anyone that's suffering can find whatever path it is to get out and live a normal life.
And thank you so much for modeling so beautifully for us that sense of vulnerability to be shared as part of a community. We are grateful, and I think all of us are taking that as part of an inspiration to continue to invest ourselves in our care and our social emotional care in this community and beyond, of course. Thank you everyone so much. I don't know where the hour and a half have gone by, but it has, and I think it could have gone even longer. We again are so grateful to have Dr. Talin Babikian and Alecko Eskandarian with us tonight, and we encourage you all, if you have time and interest and curiosity, to visit the Armenian Mental Health Initiative.org website. Any and all trainings, grand rounds that we do live on that website, so you can access it. If you have any questions for us in terms of the initiatives or things that you're interested in or excited about joining, feel free to email us. We welcome any and all interested volunteers and are eager to collaborate with so many talented professionals in the Armenian community that I'm learning about now, which is very, very exciting. And I think Yeraz and a couple of us might just linger for a few minutes. If you have any particular questions about AMHI, we're here. And if we get any questions for Alecko or Talin following this, we'll be sure to share it with them and then circle back any of their responses as appropriate. Thanks everyone so much.
Thank you guys.
Thank you guys so much.